So thank you, everybody, for sticking with us to this point. What I'd like to start by doing now, we've got Jordan and Paul and Camelia with us, is to ask the three of you whether there are comments that the day has stimulated that you would like to make, or questions that you would like to pose to any of the other speakers. And if you could, each of you enable your cameras, everybody would be able to see you as you speak. Paul, if I can direct a particular comment question to you, Camelia said she'd be curious to know of your response to her presentation. Do you have some thoughts or reactions to that? So I see that
it looks like he doesn't have a microphone available.
Yeah, his camera is on, but his microphone is not on. So Paul, if you're listening and able to enable your audio, that would be great. All right, so we're not hearing that. So Jordan, let me turn to you, if I can, and ask, from a clinician's perspective, the kind of approach that Camelia was presenting often seems foreign. In fact, it often seems to be a direct rejection of what we typically refer to as the medical model. I'm wondering if you have thoughts, both as someone who is doing research on these issues and someone who is a clinician, about these questions of whether we are in some sense at risk for doing injustice to people by conceptualizing their impairments from a strictly biomedical perspective.
Right. Yeah, I think those are very interesting questions. I think some of the issues that were brought up about the difference between, say, intellectual disability and something like bipolar disorder or schizophrenia are relevant in the sense that you know, there the impairments are often acutely recognized by people who are suffering, and there's also this difference about whether it is as identity constituting. You know, the part of listening to Camelia's presentation, and I think you were getting at this at the end, is that, you know, maybe we need to do a little bit more distancing some of these things from people's identity. That is, to the extent that something is identity, you know, when people, and I don't think this applies to intellectual disability as much, but more so to the other things, when some people vary along that dimension, I think, to which they think that their illness, let's say bipolar disorder or depression or schizophrenia, is identity defining. And sometimes with reasonable reason, that is, it is so overwhelmingly present in their lives that they, you know, it's sort of an inescapable part of who they are, and other people really want to think helpfully of it as something that is a condition that they are struggling with. You know, from clinical practice perspective, and of course this is an ascertainment bias, but people that I see who are struggling with severe mental illness or, you know, acute depression, et cetera, I think tend to be very much in the camp of wanting this to be something that obviously they themselves don't have to suffer. However, I do agree that there's something inherent about, we would like to prevent something from ever happening to anybody again, like what's happened to you, can in itself sort of be stigmatizing, because people feel a lot of shame about their illnesses, and that could certainly add to it to some degree. I mean, I think, we are in a field which is different from cardiovascular disease and oncology and so on, where those things are really not identity defining, and there aren't these kinds of ambiguities about how to think of it. And we always, I think, have to fall back on a much more nuanced understanding of how to talk about these things and how to honor people's own experience, while also recognizing that there's a reality. I mean, I worry about the other side of pure social constructivism, where there's almost a denial of the suffering that is entailed by thinking of things as, largely constructed.
So we now successfully have gotten Paul back, and let me pose the question again. Camelia had expressed interest during her talk in hearing about your reaction to her perspective. Do you have some thoughts?
Yes, and sorry about the audio problem there. Can you hear me now?
Yes.
Okay. So, no, I really appreciated Camelia's talk, and it expanded my mind in a lot of ways about things I hadn't thought about. And I particularly was intrigued by the notion of this sort of assumption of suffering and disability and impairment. And to me, I started thinking about this more in terms of this being an issue of excess certainty, where I think that as clinicians and scientists, and also loved ones, family members, et cetera, I think there's a natural urge to sort of impart one's own values and one's own judgments on the subjective experience of another person. And I think that that's what, the shared decision-making movement is trying to get us away from doing, kind of thinking about how does the patient, him or herself, see and experience and view their own suffering, and evaluate that in the context of their own lives. And so I really appreciated the perspective that Camelia put out there, because it made me think about this in a broader way. That to me, this is, maybe it's my jaundiced view of seeing everything as an uncertainty problem, but it just seems to me that what it's begging for is extra uncertainty, extra sort of consciousness of our ignorance, and kind of a humility in approaching the matter of what another human being is going through in terms of their level of impairment or existential suffering, physical, mental suffering. So that's the sort of connection that I was making, that I think your talk, Camelia, made me kind of broaden my thinking, about if this makes sense. But, to me, I just thought of this as a call for, in some ways, extra uncertainty. And I think Ainsley might agree with this, thinking about a positive aspect of uncertainty, because it is a consciousness of our ignorance. That's the way I view it. And, perhaps we need more of that as we approach another human being. So that's just kind of one dimension that your talk made me think about.
Camelia, do you have a response?
No, I think that's. I think your comments are really great, and I really actually have to say that, because I wasn't familiar with your work. It was quite unfamiliar to me, and to get this call to have a much more complex notion of uncertainty and probability was actually very, very welcome. I think with Jordan, your point about the medical perspective, and also, so I want to just make sure that I am clear that I'm not invalidating the work that psychiatrists are doing, or even the agenda, in a sense that is about psychiatric genomics, in a sense that there is a genuine desire to mitigate certain aspects of people's experiences who are going through serious mental disorder. And I'm sort of in between, because I sit in a clinical ethics group, which is comprised principally of psychiatrists. And my work is principally around the cultural, legal, and the ethical concept of disability. And so I'm constantly going back and forth between the realities that psychiatrists experience about seeing people with very serious mental disorder, and also the kind of legal context and the changes that are happening, and they are happening very radically in the UK, and also just, I think, with the convention, as I mentioned, where there is that presumption that we want to prevent certain conditions automatically is not something that is taken for granted automatically. And and I think that there just has to be some meeting in the middle. And I think Tom Shakespeare's work, for example, does a beautiful job of trying to promote that sort of integration. But it is very difficult, because as even just in the work that I do, you can see people incredibly embedded, and also have these stakes within their boundaries, within their disciplinary boundaries, and within their research agendas. And it's important to also recognize that people have these stakes, and there are costs when you start to say, I need to engage more with the disability perspective, or if you are a disability rights activist, suddenly saying, well, I'm going to engage with this genomics lens, which could lead to the justification for certain preventative strategies. And there are very virulent strands, and they're very politicized as well. But I guess the way that I see is that to move forward, there has to be just some greater mutual understanding, and fostering that mutual understanding in some respect.
So before let me just alert everybody that in a minute we'll turn to see if you've got questions or comments from anybody who's online. And again, you can either use the raise hand function, and we'll recognize you to ask a question or make a comment, or you can type it into the chat box, and we'll read it out. We'll all have access to it. But let me sort of wonder out loud. Something this discussion here has made me think about is, with regard to the peculiar predictive power, such as it is, of polygenic risk scores, which after all will often be used, or may often be used, to forecast the future as opposed to describe the present. I'm wondering whether the literature on affective forecasting has something to teach us clinically, actually, in helping people understand or anticipate the consequences of polygenic risk scores. So the affective forecasting literature, which interestingly legal academics seem to be more fond of than many other fields, suggests that, and it's been much replicated, that when we anticipate either a good event, our team winning the Super Bowl, or a bad event, losing our jobs, or being in a wheelchair as a result of a car accident, that we typically overestimate the impact of future events. That is, we're not as happy for as long as we think we'll be happy when our team wins the Super Bowl. If we ended up in a wheelchair as a result of an auto accident, for most people, it's not the end of their lives. It's a stressful event. It requires incredible adaptation, but most people adapt. So the good is not as good, and the bad is not as bad, at least not in the ways that we anticipate. And I wonder if helping people who are receiving PRS scores, particularly if they're positively predictive of a future condition, again here, a psychiatric or neuropsychiatric condition, helping them understand that their immediate reaction may not be how they feel when the condition is actually manifest, if it is, might be one way of heightening, Paul, what, you know, your notion of uncertainty not being bad, and maybe we need to increase uncertainty at times rather than decreasing it, if this would be one way of doing it. So I'm interested in any and all of your thoughts about that.
Yeah, so I'm happy to start with that. I think it's a really excellent point. And to me, that part of the discussion is a really crucial element and component of communicating uncertainty. And I think that there are many uncertainties that need to be communicated. That's certainly one of them. And there's the whole phenomenon of, as you're alluding to, affective forecasting, hedonic adaptation is another construct people have studied where, you know, once people actually achieve a dreaded state, they do adapt to it and they are able to mitigate their suffering and live a meaningful life, you know, et cetera. And so I think the dilemma is that people have to make choices and they form judgments based on the limited information that they have. And that's the human condition, and we all need to do that. But I think part of a good communication strategy to sort of convey uncertainty is to let people know that among other things, among all the other uncertainties, there's also this dimension that we will be biased. We know we will be biased in our present day judgments about future outcomes and our ability to adapt to them and live with them. We know we're going to be humanly biased to that. But my belief is that making that part of the discussion, conveying that as an additional source of uncertainty, may help to normalize that and at least help people account for that in their decision making and their judgments. And so I think this deserves, you're putting your finger on something very important. This deserves to be part of that communication of uncertainty to patients with whatever kind of prognostic information we're giving them.
I think it's hard to talk about these things to some degree in the abstract, because I think it's going to depend very much on what scenario we're contemplating using these scores in. I think prediction is probably not the first one I would think of, at least anything close to where we are now. You know, the polygenic risk scores are effectively a risk factor, like other risk factors. They probably would need to be combined with other information, although as I mentioned earlier on, so far that hasn't worked all that well. And it depends crucially on what are you going to do with it. So in some ways it's true. You might say to people, you know, it's probably not going to be as bad as you think to develop schizophrenia. You actually only have you have a 10-fold increased risk, so you have a 10% chance, which would be like what you would have if your brother had schizophrenia. It's not clear how useful that is, but also hopefully we're going to roll things out in a scenario where we might have something to offer people, because otherwise it's, there is a premium now, I think, on just knowing, because people want to know, but the knowledge isn't that good. And so, maybe this is a paternalistic medical model approach, but I would like to see that if we have something we're going to give people that's maybe a probabilistic estimate, we pair that with something that's useful to them, or there's a strategy for how to deal with it other than to perhaps adapt to the probability and not feel so bad about it in a way,
So we've got two questions from the group. So Carolyn Chapman asks, does it matter from an ethical perspective that we don't completely understand what PRS are measuring? That is, environment, unknown confounders, et cetera. And I guess I would add biological mechanisms as well, since they're agnostic towards that. Does it matter from an ethical perspective?
I mean, for me, I think it does matter. I think because there is a perception, and I think it is a common perception, regardless of how it might be, you know, a mistranslation of scientific findings or whatnot. But there is a way that this is communicated, which somehow gives this certainty, or it gives this idea that we are measuring certain things in a concrete fashion. And I think that the problem is that the potential for mistranslation is rife when we don't actually even completely understand if, you know, what it is being measured. So from my point of view, I think it is of ethical relevance.
You know, we often talk about two tendencies that people have with regard to genetic information: determinism on the one hand and essentialism on the other. And my earlier comment about the predictive use of PRS was directed at this idea of genetic determinism. I think those of you who've talked about uncertainty, Ainsley and Paul were speaking to that as well. But there's also the genetic essentialist bias that comes into play, which is this notion that if I tell you it's genetic, if I give you a polygenic risk score, it means it's inherently something about you. And not just about you, but intrinsically and inherently about you. It is your essence that we're talking about here. And I think the question actually underscores the fact that, you know, given Molly and Jordan's earlier presentations, that, you know, we're not in a position to be able to say that that's true. In fact, that other correlated factors may in fact be at play, and what we're detecting, at least to some extent here, as opposed to some, whether or not you think genetics are essentially you, we may not even be solely looking at the genetic loading that you carry.
You know, that's an interesting question. I feel like maybe you or somebody did it, because in a way, an analogy imperfectly is family history, where we don't really feel that there's some ethical dilemma in saying that you have a family history and so you have an increased risk, which, you know, frankly is, and we know that that captures not just genetics, but environment, and we don't really know what it's about. We don't know what family history is really. So have you or somebody done any studies comparing the sort of interpretation or perception of risk information communicated as family history versus, say, a TRS? We can't really do it yet in reality, but what's your intuition about how people, why or how people perceive that differently?
So I have not, and off the top of my head, I can't think of a study, although we've got a lot of good experts online with us right now, and maybe somebody will tell us that they're aware of such a study. You know, my intuition is that there is the possibility of discounting familial influence on you. The ability to say, I don't look like my parents, I don't talk like my parents, I'm differently educated and live in a different kind of place than my parents do, somehow enables one to distance family history in a way that it's harder to do when you're told that it's something in your genes. It feels like something inside you. Ruth?
I could just make a comment about that. I think it's a really interesting question. I mean, what we find, like even in my current study, that is that people really equate family history with genetics. They, you know, we're asking them how much they think their epilepsy is genetic, and they think it's totally not genetic if they don't have a family history, and the only time when they do think it's genetic is when they do. So, and I think it's an empirical question that would really be interesting to look at, because, you know, like Matt Leibowitz's work, Matt I think is online or was earlier, has shown that genetic essentialism really has a big effect when you tell people that something, that the disease that they have is genetic. But you know, that's all about molecular genetics, really. I don't think anybody's compared it with family history. I think it's really an interesting question.
Yeah, and we don't, as clinicians, have any, we wouldn't think for a moment, should I tell somebody they have a family history? I mean, usually they tell us, but as though that's a really sensitive piece of information that's toxic to people.
Yeah.
Whereas we think of the PRS potentially as that.
But it might invoke genetic essentialism in the same way that a molecular genetic test does.
And yet, well, I guess that's the empirical question that you were referring to. So we've got 2 questions in the queue and a hand up. Whether we can get them all in the next couple of minutes, I'm not sure, but let's try. Sarah Bergstresser asks, certain diagnoses such as schizophrenia and autism may actually refer to multiple biological abnormalities, which have been grouped together through the years based mostly on clinical features and observations. What does that mean for researching polygenic risk scores? Are we unable to see new categorical boundaries because we start our work with a particular legacy category framework already in place? Jordan?
I think to some extent that's true, yeah. And I think that's why a lot of people are trying to look at, so it's no longer, I mean, we've seen a lot of studies of looking at, you know, a polygenic score for something being associated with that in an independent sample or in another categorical diagnosis, but increasingly people are trying to fractionate and see what is the spectrum of phenotypic expression of polygenic risk for something. It's not a direct answer to that because you're still starting with polygenic risk that might be trained on a category. But there's a real explosion now, I think, and the hope is that there'll be a little bit more of a bottom-up look at how things are related that doesn't start entirely with our clinical assumptions.
The second question is from Dominic Bizanski. I hope I pronounced that right. You've touched upon this briefly, but can the R in PRS compute or connote resilience rather than risk? In that case, are the ethical implications or ambiguities of using this measure mitigated? So this is a sort of a labeling question. By calling it a polygenic risk score, are we in some way exacerbating the ethical or other problems that might appear down the road? Anybody want to comment on that?
Well, for me, I personally don't think that the relabeling would help, because if it is the case, then you have your polygenic resilience score is also indicating how resilient you might be in theory in the future. And resilience is also a really loaded term now in mental health contexts. And I wonder, I mean, for myself, it would have been great to have Ainsley here, because it would have been great to know how she really thought it could really mitigate some of these risks. But resilience also comes with its own baggage. And I wonder if you're just replacing one problem with another.
Okay, and then finally, we've got a hand. Bob Klitzman, your mic should be enabled. Bob, you have a question?
A comment and a question. In terms of the discussion a few minutes ago about whether family history alone differs versus receipt of genetic information, there actually has been quite a bit of work related to that with regard to other genetic tests outside of psychiatry. So for instance, with regard to breast cancer, Huntington's disease, there has been work done on just knowing your family risk or risk of breast cancer based on family history versus actually having a BRCA test. In those cases, because those tests are more predictive and actionable, for instance, in the case of BRCA, less for Huntington's, though, obviously, there's more specificity to it. So it does have a different impact than just knowing your family history alone. Of course, with PRS, it's not clear how predictive that is, et cetera. The question I was going to ask is, the presentations were all terrific today. It seems to me it was mentioned in passing that PRS has been used for educational attainment. And so I'm just wondering about uses of PRS where for more, quote, behavioral phenomenon outside of healthcare, like educational attainment, and whether people on the panel are concerned about that or concerned about potential misuse, et cetera, or what they've seen with regard to that.
So in the last minute of our day, anybody want to comment on non-clinical behavioral outcomes or socio-behavioral outcomes?
Well, I can speak. Before this, I read Robert Plomin's book, A Blueprint, and obviously he focuses primarily on behavioral genetics, and one of them is around educational attainment. I think it's very, very worrying from my point of view, because I think that it goes back to the earlier question about what are you measuring? How do you actually determine those measures? How accurate are they? And the way that they are communicated is, in some respects, as if that your genes can somehow lead to certain educational outcomes or behavioral outcomes, which I think is a reductive lens, and which does tend to ignore so many of the other complexities around human behavior and the constituents of human behavior.
Okay, well, we are at our time when we said we would finish. So I want to thank all of our speakers who were terrific. I'm sorry Molly's not here and Ainsley wasn't able to join us in person, but thank you all. We're very appreciative of your joining us today. And I want to thank our listeners and questioners and commenters, those of you who joined us online. If we see this as an experiment, I think it was a very successful experiment in terms of the number of people we were able to engage and your willingness to participate actively. So from me to you, thank you very much, and stay tuned for more in the future. Take care, everybody.
Thanks, everyone. Thank you.